Very good day to everyone. So I'm Vernon, and I'll be talking today about Singapore's public health response to COVID-19. What are the lessons that we have learned over the past 2 years, and what is the way forward for us as we try to live with COVID in the future? COVID-19 is a truly global pandemic. It's affected all countries around the world, with impact way beyond just the healthcare sector alone, affecting the societies and also the economies of many countries. The healthcare burden of COVID-19 has been felt across the world as well, as hospital cases soared in many countries, so did ICU cases and also deaths. This has overwhelmed the healthcare system of many countries, leading to disruption of healthcare services, transmission among frontline healthcare workers, especially when they're needed most to deal with the outbreaks, and provided a lot of strain on frontline workers due to the additional measures and precautions required. So I think this was seen in many countries across the world. There were also many other demands on capacity, not just on acute care, because the COVID control measures were shifting very quickly due to the changing dynamics of the disease itself. This required a lot of resources to be shunted and moved around in a very short period of time. For example, initially there was a lot of focus on testing. So there was a quick ramp up across the world on PCR tests, genetic testing, and later on a shift towards vaccination programs, from the logistics to delivery of the vaccines. I'll talk a little bit about Singapore's experience on these things later. So the key principles over the years that have been built in Singapore to deal with infectious diseases were things that we have been doing for the past few decades and remain very relevant for the current COVID-19 pandemic. So preparedness, obviously, to build our infrastructure and surge capacity and enhancing our capabilities across time. Second, surveillance in the community through multiple surveillance methods and also international collaborations to determine, for example, new variants of concern and new strains as they emerge. Third, swift and decisive response predicated on a very strong political will and clear direction, whole of society effort, and coordination within the government, but also beyond the government across all sectors. And finally, clear communications, interagency communication, so that the actions are coordinated, and also public risk communication, so that we can empower the public to take things into their own hands and to have that self and social responsibility. Now, of course, COVID-19 is not the first large outbreak that we have faced. Singapore has faced with several outbreaks across the years. And SARS in 2003, very similar coronavirus, hit Singapore in a substantial way. It was a new disease, much like COVID-19. It was already in Singapore, unfortunately, at that time, before a substantial response could be mounted. And the impact was well beyond the health sector alone. It was a national crisis. There was a lot of public concern. There was substantial economic impact. However, SARS, because of the nature of the disease, we managed to control it in a matter of about 2 to 3 months. There were also a lot of building of capacities and capabilities on the fly, standing up of capacities that didn't used to exist. So we designated a SARS hospital at that time, Tan Tock Seng Hospital, and I'll talk a little bit more about what that has meant after SARS, and that led to then the formation of the current National Centers for Infectious Diseases. We also had to stand up triaging systems and surveillance, and also building capacities such as infection control, newer and more stringent infection control practices, deployment of new technologies. So for example, on the right, we invented the thermal scanner using technologies from the military setting with the infrared scanners, and also interagency collaboration to strengthen contact tracing, roping in various agencies to assist the Ministry of Health with this. There was also a very decisive response and communications, managing public fear and anxiety, because for SARS, actually the number of cases were few, but public fear and anxiety was substantial. So there was a lead agency appointed to spearhead the communications. We even had things like SARS TV channels. We had school closures to allay fears, even though there were no outbreaks in schools, and also a SARS relief package to provide assistance for affected individuals and companies. Now, after SARS, we realized that there were the need to put in a lot of different changes across the years. And we also had different experiences. For example, the influenza pandemic in 2009 and other outbreaks that have strengthened our preparedness response systems. So national measures, we have revised our pandemic preparedness framework, built stronger interministry collaborations, built a new MOH contact tracing center, trained contact tracers within all the different healthcare institutions and across government sectors for rapid identification and quarantine of cases. In the healthcare institutions, we've built the National Center for Infectious Diseases. We've also enhanced infection prevention and control guidelines, strengthened our public communications networks, especially with the advent of social media, to be able to grasp this new media communications platforms, and also community measures such as the revision of our legal provisions, such as the Infectious Diseases Act, rolling out of public health preparedness clinics that will stand by to come in to provide assistance during a pandemic, and also to stand up, for example, dedicated ambulances to transport patients or suspect cases. And on the international front, built many bilateral and multilateral agreements to exchange information. So as I mentioned, the National Centers for Infectious Diseases, which was serendipitously launched in 2019, purpose-built hospital center with more than 300 beds, and it's a self-contained infectious diseases management facility which integrates clinical, laboratory, epidemiology, research, and training functions all under one roof. And this will enable us to manage all these emerging infectious diseases without the need to affect in a substantial way the rest of the healthcare system. And like I mentioned, it was launched in 2019, and lo and behold, we had the COVID pandemic in 2020. Now, with all these preparedness measures, one might think that we would be very well prepared for COVID-19. Well, in a way, yes, but in many other ways, not so easy. Because COVID-19 has thrown us many curveballs that were very different from other diseases. Firstly, there was an unprecedented global shutdown. And this was not in anyone's preparedness plans. I don't think any country would have anticipated border closures and lockdowns. At one point in time, the global travel actually went back to the volumes not seen since 1950s. So this has presented with a lot of challenges. Secondly, COVID-19, although it is a severe disease in some instances, especially among vulnerable individuals, on the other end of the spectrum, there are many mild and asymptomatic cases. This means that it's very difficult for us to communicate that it is severe for some, yet very mild or even asymptomatic for the majority of the population. So the policy and the communications has to deal with both ends of the spectrum. The other, of course, is infectious period. Unlike some other diseases, for example, like SARS, where most of the infections or transmission occurs when the individual is symptomatic, in COVID-19, there is the pre-symptomatic or even asymptomatic spread. This means that control is going to be extremely difficult, leading next to high transmissibility, faster rate of spread, a lot of community spread, especially with the newer variants, such as the Delta variant. And it's very long drawn with no visible end. SARS, we control it within 2 or 3 months. Even the influenza pandemic in 2009, after about half a year, most countries realized that it was not particularly severe, and there were new vaccines that emerged, and people lived with that new pandemic. But with COVID-19, it is almost 2 years now, and it is still long drawn with no visible end in sight. So Singapore's initial COVID-19 strategy was very much trying to contain the spread of the disease. Firstly, to prevent its introduction and spread through various border control measures, and also other safe management measures, such as, for example, wearing of masks, physical distancing, and restrictions of group sizes. And these are calibrated depending on the number of cases that we had locally, so preventing spread of the disease. Secondly, to detect with a very robust case finding and surveillance protocols across various means, surveillance at the borders, community surveillance, hospital surveillance, and so on. And we had also expanded our testing capacity. We started with about 2,000, a capacity for about 2,000 PCR tests before COVID-19. And right now we have almost 80,000, the ability to do about 80,000 tests a day. So huge ramp up of testing capacity. This is just PCR test. And subsequently also we have ramped up the antigen rapid testing capability. Third, providing care for all COVID-19 patients. So building up healthcare resources, and also to anticipate surges that will occur when there is the inadvertent spread, and also vaccines and also treatment research to be able to enable us to roll out vaccines and other therapeutics. And finally, containment to enhance contact tracing capabilities to deal with larger number of cases and also building up quarantine capabilities. For example, our contact tracing process. Initially, when we receive cases, we would do a very comprehensive activity mapping to determine where the cases have been to. Then we'll enrich the data using different sources, some through manual means of interviews, some through electronic means, for example, from various databases, and also from some of the new technologies that I'll talk about later. And then we would do the contact tracing. We would place then close contacts under either quarantine or phone surveillance. We also incorporate a lot of different technologies. For example, on the right, we have the Trace Together app, which is the app using a Bluetooth technology that will determine who has been in close contact with each other. On the left, a safe entry digital check-in and check-out system so that we can determine where cases have been to and whether we need to focus additional investigation activities in those areas. So for example, as I mentioned, the Trace Together app. And for those who do not use or have cell phones, we also came up with a token so that these individuals can just use that token and it would also have that Bluetooth function and it would talk or communicate with other tokens or with the smartphone apps. So all of this helped us with, for example, doing very efficient contact tracing to try to contain the spread of the disease. We also had a decisive and multi-pronged communication strategy through, for example, WhatsApp, social media, mass media, and also target notifications, for example, based on the aforementioned safe entry data. We can send SMSs to individuals who have been to affected areas. So all this helped us to contain the spread of disease. And this is a graph from Thomas Puyo, who came up with this hammer and dance approach. Initially, as cases went up, and we saw that in Singapore in about April of 2020, you needed to bring it down very quickly. And this is the hammer approach, to bring it down through a series of substantial community measures. And many countries have used the hammer to various forms of lockdowns. In Singapore, we call it circuit breaker. It's a form of a limited lockdown with a reduction in societal activities. Then after you have brought it down to a very low level, you will then dance with the disease. And this dancing involves then a calibrated reopening and, when necessary, rolling back of some of the measures as you see cases increase. And this was trying to keep cases to a lower level as possible. So in the Singapore context, on the left, we had a baseline set of measures: personal hygiene. If you're unwell, stay at home. These are things that would be sustainable for long periods of time and would be things that we would do whether it's COVID-19 or otherwise. On the right, we had, as I mentioned, the circuit breaker limited lockdown set of measures, which would be good as a hammer, but you cannot do it too often because it is not sustainable. And in between, you have a variety of other measures, such as capping the size of events or group sizes, limit the different sort of events, or even suspension of different activities, and also enhanced measures, for example, for vulnerable groups and telecommuting from the workplace. So we use these as a calibrated set of measures to reduce transmission as needed. So this graphic, which we borrowed from mass media, essentially shows initially the circuit breaker. There were a lot of activities. You can see all the crosses that cannot be done. Then after the circuit breaker, because cases were very low level, we opened up. We went into phase 1, phase 2 opening, and then more openings. But as we saw cases starting to increase, we rolled back some measures. And this was up to May of last year. So we did this in a couple of different cycles. So that was very effective. If we look at our epidemic curve until August of 2021, you can see that we had a big hammer. And then after that, you can see little small squiggles and small sort of outbreaks that have occurred, and we did that sort of dance with the disease. On the right, you can also see that at that point, there were actually quite a low case fatality rate in Singapore due to some of the measures that I mentioned earlier, like providing optimal care for every single COVID patient. But what happened after that was that since August, we had seen a sharp rise in the number of cases, even though we had achieved a very high level of vaccination coverage, one of the highest in the world. This is because of the new Delta variant, which makes it difficult or almost impossible to actually control the spread of disease once it has been entrenched. And you can see this in many countries around the world as well. So right now we're seeing cases going up, but we have a very highly vaccinated population, which means case fatality rates remain at a very low level. So how can then we continue to live with COVID-19 and move towards a COVID-19 resilient nation and not having to keep cases at a sort of a totally contained or at a zero level, which is not going to be possible to do forever? So in an epidemic or in a pandemic where there's a risk of overwhelming disease, and when there's a very high transmission, very high burden of this potential burden of disease or death, we were in a containment mode. But as we move forward, we are trying to get into an endemic state where the disease is now stable and manageable, not very different from influenza, which we live with every year, or even other diseases such as dengue. Sure, it is a vector-borne disease, but it's a disease that we live with as well. This is when transmission is controlled. It's not zero, but it is controllable, and the severity is manageable, such that we're able to deal with the cases that we have. So in a pandemic mode, like I mentioned, goal is to eliminate transmission, very aggressive and comprehensive contact tracing, quarantine, isolation management, and community measures roll out. And the features are that it's very resource intensive because we're trying to contain the disease. We're now moving into the preparation or preparatory and transition phases or stages where the goal is to continue to test, continue to do some form of contact tracing and advice for individuals while increasing the vaccination and booster shots in the population and a graduate tapering of the test, trace, and isolate protocols. The features here are to maintain the capacity and to understand and gain confidence in this calibration of measures. And moving forward, in a COVID-resilient nation, we will live with COVID-19, where we have a new equilibrium, where we can reduce severe infections through vaccinations and boosters, where the focus will be a lot more on social responsibility rather than government mandates and laws. And we will move then to a sustainable long-term peacetime measures, very similar to what we do for influenza, but also to maintain preparedness in case of a future wave or a new disease X. So elements of moving into this next stages, firstly, vaccine availability and deployment. Second, calibrated reopening of society and economy, trying to understand as we relax, what is the impact, and therefore we can better calibrate that. Reopening of our borders, because Singapore is an island and we have to rely a lot on trade and travel. Next, to ensure that our healthcare capacity is able to cope with the number of cases that we have, and also to look for new treatment modalities and to incorporate them into our health, our clinical management. And also, like I mentioned, preparedness for future waves. So some of the things that we have been doing, we have been rolling out vaccines and now boosters. And the key elements of such a plan include securing vaccines, ensuring the safety and efficacy in these new vaccines, to have a comprehensive and responsive vaccination strategy, sustainable deployment of the vaccines, and we have done that through rollout, through setting up of many vaccination centers nationwide, and also proactive engagement and public communications so that the public is aware of the benefits of the vaccine and now of boosters and has the confidence of actually going to get their shots. So this has been extremely successful. The vaccination coverage in Singapore is now more than 85% of the entire population, or about 95% of the, more than 95% of the eligible population. And we've also been rolling out booster shots for those more than the age of 30 and also for frontline workers. So reducing the impact of COVID-19 is possible. Without vaccines, the impact of COVID-19 is substantial. This is a table. We've gotten some initial data from Israel on the left, and on the right, you're comparing it with seasonal influenza both in Singapore and other countries. You can see in unvaccinated individuals, the rates of hospital admission and death is quite substantial, and that was why there was a lot of concern about COVID-19 as a pandemic very early on. However, you can see that for vaccinated individuals, the rate of hospital admissions and deaths drops quite substantially, and is quite comparable to seasonal influenza in Singapore and to the rest of the world. So with high vaccination coverage and now with boosters, it is possible to make COVID or to have COVID-19 be of similar severity to influenza and other circulating diseases. Now, COVID-19 is obviously not the same as influenza. I'd like to emphasize that, because there are a lot of other things about COVID-19 that we do not yet know about, whether it be long-term sequelae, and also the waning of vaccine effectiveness, which are now covered by boosters, but we do not yet know what is the long-term effectiveness of the vaccine and whether new strains of COVID-19 may emerge. Now, while we can be hopeful, it's things that we have to do more research, we have to study this. But what this all means is that with the current technology that we have and the current knowledge that we have, it is possible to move into living with COVID and moving into a COVID-resilient nation. So to do this, we have also now, in moving on to this COVID resiliency, we have tried to simplify our health protocols. Where previously we were trying to cover all angles to try to contain spread, now we're trying to make things simple so that people can take things into their own hands and to have that self and social responsibility. So for example, in the first protocol, if you're unwell, consult a doctor, get tested, and then if you're PCR positive, you will have to isolate at home. It's a requirement, and then you'll be discharged after a certain number of days. Now, if you're well, but you test positive on an antigen rapid test, then you can self-isolate at home. And after that, if you test negative, you can be released and move around and do your own sort of activities after that. But if you're unwell, you then go to the first protocol. Third, if you're identified as a contact or close contact of a case, you need to take an antigen test immediately and report it. And then if you want to go out of the house, you have to take additional antigen rapid tests every day that you want to go out for 7 days. And in the end, you just take a test, and if it's negative, you are then released from the protocol. If positive, you would then go to protocol 2. So all these make things a lot easier for individuals, and we're moving away from quarantine by legal orders, for example, to put a lot more self-responsibility to the population. And the other thing that we've also realized, and this is a study done by other international colleagues published in JAMA, showing that while vaccinations might provide a good reduction of number of new infections, it still needs to be balanced with other public health control measures because there needs time for example, vaccination distribution and now boosters to take effect. So you can't just open up widely because you will see cases shoot up very quickly. Calibration of the measures will still need to be done, and that's what we are doing currently as well. And finally, the rollout of vaccine differentiated measures, because what we've also realized is that vaccinated individuals have 3 things going for them. Number 1, they have a reduced risk of infection. Secondly, more rapid viral clearance compared to unvaccinated individuals, and also milder disease, which means that with rapid viral clearance and milder disease or even asymptomatic disease, they would be less likely to transmit disease to others, which means that we can allow vaccinated individuals a bit more leeway in terms of the public health measures that we impose on them. So in terms of vaccine differentiated measures, and we use the same Trace Together app on the right, and you can see there that vaccinated individuals would have this green check. And with that, we allow them to, for example, dine in at food and beverage establishments, go into malls, etc., because they would be safer in terms of disease transmission. And also, should they inadvertently get infected, the outcomes are also going to be on balance less severe than unvaccinated individuals, and they will not choke up the healthcare system. So what are some of the opportunities and lessons that we have learned from COVID-19 as we currently continue to battle with the disease? One is that we have to be adaptable. COVID-19 is very challenging because it keeps changing and the disease is evolving. It is a force of nature. So we have to continue to adjust our protocols and measures based on evidence. We also have to optimize the use of technology where relevant. And where not relevant, we have to then adjust and move on to new technologies or different technologies. Second, sustainability. We have to ensure that response plans remain sustainable because COVID-19 is going to be with us for the long term, maybe forever. We have to ensure sufficient healthcare capacity, both for COVID-19 and also for routine diseases. And look at then vaccination, vaccine boosters, and also new technologies for treatment. Transparency. The government has to have the full support of the people. So we need to communicate well, have a whole of society approach, and also, like I've mentioned earlier, clear and simple communications. So in conclusion, to deal with COVID-19, we have to be prepared and stay nimble. We have to have good collaboration and coordination. We have to harness new technologies and have good communications. And with this, we'll be able to transit and move to a COVID-19 resilient nation. Thank you so much.